Now let's turn to our presentations. You will hear from three leading experts in the field today, each bringing a unique perspective to the discussion. First up will be Professor Emerita Carol Brain from the University of Cambridge, who will introduce the foundations of population-level approaches to dementia risk reduction, drawing from decades of research and international experience. Then next up, we will have Dr. Sebastian Walsh, also from the University of Cambridge, who will report the findings from recent studies relevant to population-level approaches to dementia risk reduction and discuss future directions. Third up will be a name that is probably familiar to many of you, Dr. Aotearoa Mau from the University of Auckland, and he will highlight the differing dementia risks across Aotearoa New Zealand's diverse populations, and thus make the case on why population-level approaches to dementia risk reduction are needed in this country. All right, now let me briefly introduce our first speaker, Carol Brain, who is joining us virtually from Cambridge, UK this morning. So good evening to Professor Emerita Carol Brain. As I've mentioned, she has been on the forefront of the dementia epidemiology and public health field for 4 decades. She co-founded the population-level approach to dementia risk reduction research group and co-led the group prior to her retirement in late 2024. Amongst a plethora of leadership positions, she was director of the Cambridge Institute of Public Health for over 2 decades. She is a fellow of the UK Academy of Medical Sciences. She was awarded a Commander of the Order of the British Empire from the late Queen for services to public health medicine in 2017, and she ranks among the top 100 female academics globally. Carol is also a key figure behind our workshop here in Auckland, as she has facilitated almost all of the connections of researchers who have gathered here. Yesterday, during our first workshop day, we really reflected on the huge influence that Carol had on most of us. And Carol, while you cannot be here with us today in Auckland, we are really grateful that you have joined us online, and we all look forward to hearing from you about the foundations of PLADRR. Over to you, Carol.
Thank you so much for that introduction. And I'm so thrilled to see so many people joining this public lecture in New Zealand. Actually, I think it's the first time I've ever given a lecture in New Zealand, so I'm really sorry I'm not there in person, but it's wonderful that so many of the folk who are interested in this area have convened for this really important workshop. And I'm very grateful to Professor Cullum and Susanna Rohr, who's just spoken, and all the New Zealand team and all those who've come in from abroad for basically taking forward these concepts. I'm going to give you, having been involved in the field for 40 years, I'm going to give you a bit of a skate through the research and the learning in that time. I mean, it's been a privilege to be involved in this field of research, but I am sure, as you can imagine, everybody on the call, when I joined the dementia research field in 1985, so it is 40 years, there was pretty well no one working. There were very, very few people working in the field. And it couldn't be more different now. It's really quite extraordinary. And so much progress has been made. Huge advances have been made in terms of awareness and care. And we've also made great strides in epidemiology. And it's, there's a big cadre of folk across the world working on this. And I'm just going to try and share my screen and make sure that it is actually working. Can you see it now? Can you see a full screen? Can somebody tell me whether you can see the full screen and that I'm sharing my screen?
Yes, Carol, we can see everything. Thank you.
Fantastic. Okay, thank you. Because I've got several screens up, so I do want to make sure it's the right one. So I called it Creating the Evidence Base for Dementia Risk Reduction Over the Decades, and it's a very personal basically trajectory. And of course, there is much other research that has been going on during this time. But there have been relatively few people working in the field of dementia epidemiology across the world. And so this does reflect a kind of the evidence base that we have managed to generate. Just to note that there are inequalities in Cambridge as well as elsewhere in the world and in the Cambridge region. And although Cambridge is very beautiful and lovely and has the university and so on, we also have our homeless. So I just wanted to point that out from my first slide. And that's been something that I have become increasingly interested in as both a public health person, but also as a dementia researcher. So first of all, I know this is a public lecture, so most people who are on the call will be very familiar with what dementia is, but I wanted to reflect for a couple of minutes on what is dementia. And it is really quite a difficult concept. It's a syndrome. And the areas that make up the syndrome, the criteria, so how we diagnose dementia in the population or in people, is made up of different components. One of those things is mental functioning, so cognition. I think most people have become aware of and are very familiar with all these terms now, but when I started out, people weren't really familiar with these terms. But another key area of the dementia syndrome is how we manage day to day the functions that we need to do. And so that's often called activities of daily living or instrumental activities of daily living. And those need to be impaired along with cognition. So the cognition has to be impaired over time and sufficient to interfere with daily functioning. And then there are exclusion criteria, which can include reversible causes and things like, so say, thyroid disturbance, so and hormonal disturbance. But there are many different causes, and depression, mood state, and so on. So there are quite a lot of exclusion criteria, and also to exclude what we call delirium, which is a kind of an alteration of consciousness, which can be associated with all sorts of things, such as infections. So the syndrome is not kind of you've got it or you haven't. It's much more something that develops over time. And each of the things that you have to measure in order to make a diagnosis are also not binary. So they're not 0, 1. You don't either have it or you don't. So as you can imagine, measuring cognitive function, measuring mental function, requires lots of different types of tests. And those tests have scales, often, which might go from 0 to 30 or that kind of thing. And you have to decide what is normal and what is abnormal. And of course, that depends entirely on what population you are measuring that thing in. And the same thing applies to daily function, because of course, if you're a 40-year-old working in a very complex job, and you begin to have difficulties with functioning in your work as a result of early onset dementia, that is a very different thing from being 90 and being quite frail and having a great deal of support already in place, and the daily function that you need to kind of cope day to day will be different, and different cultures are very different as well. So those are the syndromal angles of a diagnosis, but then there are the subtypes. And those subtypes have come to great prominence in the last decades, Alzheimer's being the most frequently named. But there is also, of course, a plethora of other causes of dementia or thought kind of underlying causation. And these are variably looked at in research. And there are specialists who look at each of these and kind of focus in on different types of dementia. And in those research worlds, they tend to really only see that part of what is a very complex picture. So dementia syndrome in the population is much more than Alzheimer's or vascular or Lewy body, each one of these. And of course, it's very important that we have specialists who look at the very detail of the drilling down into those particular types of dementia. But it's also very important that we come out from that very detailed work and look at the entire population. And that's really been my kind of task, if you like, since I started out in epidemiology, which is the study of the distributions and determinants of disease and ill health in populations and across time. So I'm just going to give you some results from studies that I've been involved with and led over the years. And one, it was in East Cambridgeshire, and it's a very flat area. That's actually, it's below sea level, north of Cambridge. And although it's called East Cambridgeshire, it's actually north, it's sort of fens, it's called the Fens. And then one in Cambridge City, which also which covered the whole of the city, Cambridge City, people aged 75 and over, and then the cognitive function and aging studies, which were as a multi-site study in England and Wales. And I'm just going to give you a snapshot of some of the results that have come out over the decades. So the very first study that I did was really looking at that syndromal aspect. I wanted to look at the distribution of the measures that you use to make a diagnosis of dementia in the population. And in this case, it was women aged 70 to 79. It was hundreds of interviews, also interviewing relatives or friends, people who knew the person well, about whether they had changed across time. I was very fortunate. There was a very high response rate, over 90%. And this shows you just simply, it's a simple histogram of the frequency of different scores on the cognitive test mini mental state, which is used globally. And what it simply shows is that there's a kind of continuum of scores for both for the population, and that for the older population there's a slightly lower distribution. I hope you can see my cursor there, just tracking the older folk, and that shows that there is this tail end, and most of those people in this area did reach a diagnosis, the criteria for a diagnosis of dementia as used in that study. So this shows a different distribution, but of course this is what we call cross-sectional. It's not studying people across time, it's just a snapshot. And so anything like education could affect how well people perform on these cognitive tests, because if you're not familiar with these kinds of tests, they're actually really quite difficult to do. And this has been demonstrated across the world when people mistake the fact that people have not had much education for dementia, and it's a very difficult area of study. So some countries in the past have had apparently very high levels of dementia diagnosis because they've had low levels of cognitive function or these tests, performance on these tests. But actually it's largely, particularly women, and it's largely because those women have not had access to education. So you have to have some familiarity with cognitive testing. All the cognitive tests have to be very well adapted to populations who have lower levels of education. So that shows a kind of continuum for cross-sectionally for the measures that we use in our diagnoses. But how much dementia was there at that time? So I'm just switching from the continuum now to the binary, because to make a diagnosis, you have to make a decision about who is kind of has normal function and who has abnormal function. So you do have to divide it because it's very important in the diagnostic process. And the study that I just showed was also part of a European exercise, which brought all the studies which were in the population, true population studies, going out and interviewing everybody in particular geographical areas of a particular age. And this shows the studies that there were at the time in the late 80s and early 90s. As you can see, it's a 1991 publication. And that generated these findings, which showed really very, very clearly, although this was largely sort of known, but very clearly on large population studies across Europe, that there was a very dramatic increase in the proportion of people at any given age over the age of 60, as they age, who meet the criteria for the diagnosis of dementia at the time. And also that apparently there wasn't that much variation across countries. So these are all the different countries. Down here you can see the legend. These are the same data, but shown on a logarithmic scale, which shows you the extraordinary linear, so it just goes up in a straight line. And that really gives you a very dramatic illustration of the fact that it's so strongly associated. Dementia as a syndrome is very, very strongly associated with age. So that was very useful from a policy angle, because it showed the prevalence of dementia, the proportion of people at any given age who might have dementia or be diagnosed with dementia, be living with dementia in different across Europe, and that fed into policy and also fed into the funding of research. And so the epidemiological data, just simply having descriptive data on the population in a representative way, was crucially important in knowing what was happening in the population and what society might want to do about that. In terms of supporting people living with dementia, their carers, and also thinking about the future. So coming back to the continuum, however, the second study that I showed, which was the Cambridge City over 75 cohort, was a study of people aged 75 and over, almost everybody, well, a huge proportion of the people aged 75 and over in Cambridge City at the time, conducted in the mid-80s. And that we were able to continue into a longitudinal study. And so this was the 2-year follow-up of the same cognitive score, the same sort of test, and looking at how people changed across a 2-year period in the 75 plus age group. And what you can see here is that there's a distribution, there's noise if people move. So it's a lovely normal, what you might call a normal distribution, with some people getting better, some people not scoring so well. But in general, people were scoring a little lower. So this shows that in the whole of the general population of that age, there was a general shift in cognition downwards, and that there isn't any kind of sharp distinction between the people who might receive a diagnosis of dementia, but there's no sharp distinction between these people and the people in the general sort of shift downwards. So it's a continuum. And so we just have to be aware that we do artificially impose these binary 0-1s onto populations in an important way, because it is important to make diagnoses. For people to receive services, to know what the size of the issue is in the population. This study, the Cambridge City over 75 cohort, provided the opportunity to continue to follow people across time, and this is a 10-year follow-up in those people, and we managed to follow up lots of people. The response rates were pretty high in those days. And what happened, what this analysis shows, is that you really need to follow people up and be aware of those people that you don't see. And what these different lines are different types of analysis. So people who were seen at each time, people who were observed at any time. So these are the people who made it to here. This is the actual results at each occasion. And then these are the, if you like, trying to put back in the people who've dropped out, who refused and who died in between waves, and looking at what their scores were, what they might have been had they been seen. And what you can see here is that if we only rely on what we see in population studies, and we're following people longitudinally, they're not cross-sectioning longitudinally, we will underestimate what the size of the issue is in the population. So we have to be very careful about the way that we do our analyses. And that is a repeated finding. We were also very interested in these subtypes, and one of the things that we were able to do was look at the neuropathology. So we were very fortunate that we were we could invite people to take part in a brain donation program after their deaths, so making a fantastic contribution to our understanding of the biology of dementia and normal aging in the brain. And in an unselected way, we were able to look at these concepts of Alzheimer's disease, vascular dementia, Lewy body, and so on. And here is just simply looking at people who are dying with and without dementia. So we follow people right up to death and looking at their brains afterwards. And this is on several hundred brains, or this one actually is a smaller one. This is more like 100. But I'll show greater numbers in a moment. The light grey are people dying without dementia, and the dark grey are people dying with dementia. And these are kind of hallmarks of Alzheimer's disease: tangles and plaques, and also sticky proteins in the blood vessels as well, so a vascular type of thing, and then vascular disease more generally, like stroke and infarcts, that is, and different types of changes in the blood vessels of the brain. But what you can see, I want really just to highlight this. I think what you can see is that these distributions where you've got people dying with dementia and people dying without dementia, that there's a great deal of overlap. That in these very old populations, and most of these brain donors were aged over 80, well into their 80s, that when you get into these older age groups, it's not that a small group have Alzheimer type changes in their brain and they all have dementia. It's much more complicated than that when you look when you drill down in populations and do this kind of detailed work. The last group of studies that I showed, where I showed the photos and the different sites, were the cognitive function and aging studies. And those have provided also prevalence estimates for the UK, which are still used. And one of the things that we were able to do with that study was look at the survival of people who developed dementia during the study. And what we found was that the median age of onset of dementia in our population studies was 84. The median age at death was 89. So survival was about 4.5 years for women and 4 years for men. And the best predictor was how impaired their functional ability was, the day-to-day function. And that's quite helpful to have some sense of prognosis. But of course, for any given individual, it's really difficult to make a very strong prognosis of how long they will live and how well they will live during that time. But this was at least an attempt from our longitudinal data from about 18,000, from about 10,000 deaths in 18,000 people. So that the cognitive function and aging studies was a very big study. And we were able also to look at the prevalence or what happened towards the end of life at death, and work out whether people had dementia before death. And this slide begins to look at advantage and disadvantage. So the top one is is gender, and you can see that women have are slightly more likely to die with dementia than men across the age groups. And again, this is in 10,000 deaths or so in the cognitive function and aging studies. And you can see there's a significant difference, although it looks relatively small, it's actually very significant by social class. So this is just sort of non-manual and manual, so very crude classification, but that's what we were able to do. And then years of full-time education, we also have the same kind of separation of the proportion of people dying with dementia according to full-time education. And this is it's apparent across the age groups, apart from that youngest age group for the education finding. And this seemed pretty important, and it's one of the things that we've pursued during the study. Challenging and testing the relationship of the very prominent pathologies in the research world, which are the Alzheimer's type in this case, and the presence of dementia in older population, was something else that we wanted to study. And so what you can see here is that if you look in a pretty large sample, again, this is the cognitive function and aging studies, in which we could also have a brain donation study. We have here the prevalence of the pathologies of these pathologies, atrophy here, and plaques and tangles. So atrophy is shrinkage of the brain. Plaques and tangles are the hallmarks of Alzheimer's disease. And by looking here by age, what you can see is the proportion having these pathologies with age. For atrophy, it goes up with age, but it's got a consistent relationship for having dementia and not having dementia. And the same thing is in different parts of the brain. So this is the sort of top end of the brain, and this is the hippocampus, which is often thought, well, it is very much associated with Alzheimer's disease. And here we have plaques. And what you can see here, though, is that the relationship of dementia and those dying without dementia and the pathologies changes across age. Same thing with tangles, and so the pattern is the same in the neocortex here. So you can see the relationship is changing with age, and this has clearly got very profound implications for thinking about things like early detection of dementia by testing for Alzheimer type pathology changes in the blood or in the cerebrospinal fluids. This slide shows the fact that we were able to look at education and neuropathology and the presence of dementia. And this is 3 population-based studies. So this is the 2 studies I've described already, and one from Finland, which is in even older populations. And what it shows is that for, this is an example, but for one particular type of pathology and for others as well, but this is an illustration, that levels of education appear to protect from the presence of dementia. So the percentage of people who died with dementia with these types of pathologies, and every single level of that pathology, less people in the oldest age groups, in the highest education had expressed dementia during life. So the less education, the more likely you were to have dementia. So that brings me, sort of circles me back to the comment that I made at the beginning about the challenge of looking at education and cognition and dementia. This study does show that education does appear to protect to some extent from the presence of dementia. And other studies have had the same findings. It's not entirely consistent across all findings in the world, but there is a body of evidence to suggest that education does protect. It's not just a kind of measurement issue. Coming back to the mixtures of pathologies in the brain, this is a very important study that was done bringing together different groups from across all high-income countries, and it's basically USA and UK really, and what we were able to do with this study was look at how pathologies co-occur and how much dementia and no dementia there are. So again, this is a post-mortem studies, neuropathologies in the brain, where people have been studied across life. And what you can see here is this types of pathology here and what the combinations of pathologies are, so, and what the proportions of those people dying with those pathologies had dementia. And so what you can see here is that even where you've got very few pathologies in the brain, you've still got a significant proportion of people who have died with dementia, but that as you go up with the increasing combinations of pathologies, you have a greater proportion of dementia in those people at death. And this is very important here because you can see the vast majority of the people dying in these studies, which are population or community-based, have got mixed pathology. And that's a very important finding that is under-recognized in the research world and basically understudied, but it's very consistent across our population studies in the few international studies that have been able to look at pathologies after death. So moving on to the fact that we were able in those studies to look at risk and what might be important in dementia. So education is the thing that I've focused on so far. But of course, there are vascular changes, which I've also shown are present in the brain. So there's all sorts of risk factors which are associated with vascular disease, which have been consistently shown across the world to be associated with increased dementia risk, such as stroke. Parkinson's disease has also been associated with doubling of risk of dementia over time, and that's very consistent now. So there were various things that were changing in the population. So dementia so that factors associated with dementia, such as vascular risk or stroke, were changing in the populations that we in the UK and across the world, particularly in high-income countries. So we thought, well, that might change the occurrence of dementia in the population. So we managed to get funding for the CFAS-2 study and recruited a completely new lot of people aged 65 and over. And we did find that there was a dramatic reduction in the proportion of people who met the diagnostic criteria, the same diagnostic criteria that we'd used. And this was about 20 years of difference in the population studies in the same geographical areas. And you can see that these are quite dramatic differences, about over 20% reduction in the prevalence of dementia across the generations. A very important finding, and not isolated to the UK, to England, but also shown in France, in the USA. So these are several: USA, Sweden, and that's another French study at the bottom of the Free City. And this is not prevalence, this is incidence, which is new occurrence of dementia. So we pooled all our data in a big kind of putting it all into a bucket, if you like, and analysing all together. And what we found was that there was a significant, this is less than one. And I know for many in the audience, this might not make much sense, but this is the line, if there'd been no change across time, this is the line that these little blue squares should be on. But they're all left of that line, which means that over time, the new occurrence of dementia is going down in the populations that have been studied. So it's a very important finding, and one which is not that kind of highlighted. Why? So people have tried to think about why. There are many risk factors for dementia, and there's been a very big exercise called the Lancet Commission on Dementia, which has been now through 3 iterations. And several of the folk in the room in New Zealand have been involved in this latest iteration, and I also have been involved. And what that exercise did was bring together as much of the world literature as possible to look at risks for dementia and create a kind of life course thinking about where risk might be operating in the life course. And so you can hear early life, we've got less education, middle life, hearing loss, cholesterol, depression, traumatic brain injury, physical inactivity, diabetes, smoking, hypertension, obesity, and excessive alcohol. And then later life, social isolation, air pollution, and visual loss. And these were all risk factors that were deemed to be sufficiently robust internationally to be included into this analysis, where their interrelationship was taken into account as much as is possible. And about 45% of dementia was felt to be potentially modifiable. And so this is bringing together the world literature. It's a huge exercise and a very impressive one, and it's helping to shape policy. And that's one of the kind of underpinning aspects of the population levels approaches to dementia risk reduction. So we know that the risks for dementia are highly associated with with deprivation, and these are just some UK figures to bring us to the end of my bit. And so this is stroke. It shows you least deprived, most deprived, and I know this is of great interest in New Zealand. And you can see there's a huge relationship here with any type of stroke. Same thing for stroke, for the stroke risk factors: diabetes, atrial fibrillation, and hypertension. So although our cognitive function and aging studies were going in the right direction, all of these things are still associated with inequalities. And in fact, the improvement in dementia in our populations was largely seen in those who were more advantaged. And so Seb, who you will hear from in a moment, worked on thinking about a life course kind of visual, which brings into account all these wider experiences and influences on how our brains age, and therefore how resilient we are, what protective factors and what risk factors we accumulate across the life course. And then finally, sort of in a way, the dementia is a final common outcome, but it does affect all of brain health and indeed wider health, but neurological disease outcomes in this particular visual that is absolutely appropriate to dementia. And that's in the public domain. But it covers all of the things sort of I've been talking about, but also the biological underpinning of how that might be working, how these risks might accumulate and create pathology in our brains. So I'd like to stop there, and because I know Seb is going to come next and kind of pick up the baton, and just acknowledge the fact that these studies have been led. I've had the privilege to lead and be part of, and have involved a lot of universities, a lot of international collaborators as well over the years, and many participants, donors, and hundreds of thousands of interviews, as you can imagine, and our funders. Thank you. No, stop share. Here we go. I was delighted to see so many thoughts coming into the chat about the key factors.
Absolutely. Thank you so much for your excellent presentation. We do have time for one question now, and a reminder for everyone, we will have a dedicated Q&A session at the end. So for now, I just want to pose one question that has been posted in the chat. So Carol, regarding the links to education, does the impact of education change depending on when in life someone pursues that education? For instance, if you get a certain education earlier in life, let's say 25, you go to university, or when you're 55. So does that change the impact of the education on dementia risk?
I'm not sure I can answer that question directly because I don't think it's been studied in that way. Most of course, the power of our findings has been largely from early life education. But what I can say is that there is a lot of work that's been done on if you like, intellectual stimulation across the life course. And in early life, that tends to be education. In midlife, it's occupation. And in later life, it's very much engagement, social engagement, and that kind of thing. And those studies have shown that each of those things has an independent influence on cognitive trajectory, on how your cognition changes across time, and also whether you can recover from an impairment. So you sort of the recovery is better the more education or higher sort of intellectual stimulation in your occupation, or social stimulation and intellectual stimulation in later life. So there's a kind of circumstantial evidence that would suggest that it's good at all life stages, even though I don't think specific sort of midlife education has been studied directly.
Thank you so much, Carol. If you have more questions, feel free to post them in the chat. We're now going to move on to our second presenter, and I'm delighted to introduce to you Dr. Seb Walsh. Seb is a public health doctor in Cambridge, UK. He is with us today in Auckland. He holds a really central role in developing population approaches to dementia risk reduction and the international research group around that. His work is at the interface of public health research and policy, and he mostly focuses on applying a population lens to dementia, including primary and secondary prevention, working directly with policymakers, and he utilizes all sorts of different quantitative and qualitative methods that incorporate different perspectives from public health, epidemiology, clinical medicine, and others. He will give you a good overview of the current state of the research regarding population level approaches to dementia risk reductions, and talk a little bit about future directions. And here he is.
The slides are ready. Okay, hopefully you can see my slides online. They can't because we've muted them. Okay. uh, perhaps if someone could
Yes, we
just tell me.
can. Yes, we can,
Oh,
Seb. We
thank you,
can.
Carol. Oh, while you're there, Carol, can I just double check you're going to be here for the Q&A after Etu's talk? Is
Yes.
that going to be okay with you? All right, great. Okay, thank you very much, Suzanne. I'm very impressed as I managed to make my introduction as long as Carol's. I don't have a CBE just yet. So that was a really amazing talk from Carol, talking about several decades of evidence to lay the foundations for us to understand that dementia risk can be lowered, and to start to think about the ways in which we might do that. And that's really the baton, as Carol said, that I've tried to take forward over the last 5 years, working with her and others to develop evidence about how we turn some of that observational evidence into policy-facing evidence that we can try and use to influence policy. So the question that really motivates me across all of my research is how we reduce dementia mobility by as much as possible. And so just to illustrate that point, so this circle, I'd like you to imagine, represents all dementia mobility. So all the suffering of individuals who have dementia, everything that their loved ones and carers go through, and also all the health and social care costs in the system. And that's not just today, but tomorrow and the next day and around the world. And I think when we do our research, we must ask the question that when we put our outputs of our research alongside other people's, there's some kind of enduring impact that we're aiming for, and that's going to remove some amount of that mobility. And I think everybody involved in dementia research, whether it's prevention, interventions, or care, should be able to draw this logic model and really examine the assumptions within it as to whether what they're doing can produce some kind of scalable benefit. And hopefully some of the things we talk about in this talk and some of the things that Carol talks about will help people to do that. Many of you be familiar with the tiers of prevention. So this is the idea that we can either try to reduce mobility by stopping disease happening in the first place, which is this bottom end of the triangle, or by intervening early, or by reducing the amount of disability in established disease. We're obviously focused at the bottom end here, but I think these principles apply right across that triangle. Now, you might be thinking, why am I being so utilitarian about this? Sometimes public health people are accused of being a bit utilitarian and not thinking enough about individuals. And I think that's a fair challenge. One answer, obviously, is these forecasts, which we see. This is for New Zealand from our next speaker and team. But we see these forecasts across the world where the prevalence of dementia, or the number of cases of dementia that we expect to see going forward, is exponentially increasing. And as Carol's just shown, that's not necessarily because a given 80-year-old or 90-year-old is more likely to have dementia now than a generation ago. What we're really seeing is this is driven by aging populations. So this is the old age dependency ratio around the world. So this is the number of people 65 and over compared to the people who are of working age. And this is our high income countries up here. So in the UK, when we founded our health service at the start of this graph, we had 6 people working for every retired person. And now we have 3. So we've effectively halved our supply to demand in terms of workforce and also sort of tax paying. And what you can see is that the upper middle income countries have an uptick which is much sharper than that steady increase we saw in high income countries. So that demographic shift has happened much more quickly in countries like India and China. We're starting to see it in low middle income countries. I actually, very remiss of me, I'm afraid I forgot to put on the lower income countries, but they would be flatlined around 5% for now, sort of sub-Saharan Africa area in particular. But this very quick uptick in the countries who've gone through this demographic transition most recently is worrying, because they don't necessarily then have the time to transition their systems across. So we do have to be nakedly utilitarian about this because of the scale of the problem. The other reason I think we need to think in that way is because dementia risk and dementia prevention, dementia protective factors, reserve, they build slowly across the life course. We just heard about the role of education and early life education, but all of these things, occupational stimulation across many, many years of a working life, exposure to air pollution, exposure to cardiovascular risk factors, obesity. These things inch along slowly as we get older. And so if we try to do some kind of blockbuster intervention when someone's 65 or 70, what we're asking that intervention to do is undo 60, 70 years of pathological accumulation. And I think that it's difficult to see how we're ever going to get effect sizes that are big enough from those kinds of interventions based on the current evidence to really undo all of that. But the flip side is we cannot, bash people over the head when they're 7 about their dementia risk. So we have to do this in a utilitarian way, in the sense that we have to take this population level approach, because we need to try and achieve small changes for lots of people from multiple interventions as part of a strategy. So then the question becomes how we go about lowering that risk. And we've heard a little bit about that from Carol. The Lancet Commission risk factors that she mentioned in that nice S-shaped diagram are here in the blue. And there's various pathological mechanisms that we think they lead to. Problems with the cerebrovascular system, neuropathological changes that Carol talked about, stress, inflammation. And then on the flip side is trying to build cognitive and brain reserve. And all of these lead to us, if we get it right, managing to slow down the development of dementia on average across the population, so that some people will get it later than they would have done, and some people will die of other things and won't get it at all. But the question is how we go about doing that. How do we take a step backwards the other way to influence these blue things? And for that, we tend to, this is Geoffrey Rose, who many of you will have heard me talk about before, but he was an epidemiologist at UCL. And the year before he died, he wrote this, or published this book, The Strategy of Preventive Medicine. And he asked us to imagine, and not imagine because Carol showed us several of these normal distributions in her talk, that risk of a disease exists on a spectrum. So some people will have all of those blue risk factors that we just talked about, very little protection, and they'll be very high risk. Others will be at the other end, very few risk factors, lots of protection, very little neuropathological damage. But the vast majority of us are somewhere in the middle. And so we can try to reduce risk in the population by identifying those at the highest end of risk and trying to truncate the distribution by moving them to the left. But what Rose argued was that these people often are, say, at 4 or 5 times the risk of the general population. But there may be hundreds or thousands times more people in the center of the distribution. So if we achieve a small change for that whole curve, shift the whole curve to the left, that will result in a much greater reduction in future disease, because that's where the majority of population risk exists. And of course, the high risk group are moving here as well, but maybe not by so much. And so he had this line, which a large number of people at a small risk may give rise to more cases of disease than a small number who are high risk. And one of the studies I've been doing over the last couple of years is this one, to try and actually empirically look at that in the context of dementia. So we took a population-based cohort in the UK, Epic Norfolk, which has 30,000 people from baseline, and we have about 30 years of follow-up on them. And we looked to see who got dementia and who didn't during those 30 years. And the people who went on to get dementia are in this, represented by this red curve. And the people who went on to stay cognitively healthy are in the blue curve. And what we did is we applied various dementia risk scores to them at baseline. So imagine in 1990, we had said we're going to risk profile all of Norfolk in the UK, and we're going to pick out the people who are in the top 10% of risk scores, and they're going to be our high risk group. And we're going to work intensively with them to try and lower their risk through, say, a lifestyle-based intervention or medical intervention. What we found was that 70 to 80% of the people who went on to get dementia were never in that high-risk group. No matter which risk score we used, no matter which cutoffs we used, they were always on the left-hand side of that line. So had we done that intervention in 1990, 80% of the people who would have gone on to get dementia would have been excluded from the intervention because they weren't high-risk enough. The flip side of that, of course, is that some of the people in this high-risk group didn't get dementia, so we would have informed them that they were high risk, worked with them. They may have had other benefits, of course, but they wouldn't have actually benefited from the dementia prevention intervention because they weren't going to get dementia. So we're confident from this that we can say that dementia, the Rose's hypothesis that most cases come from the middle of the distribution, it does hold for dementia. The question then becomes how we move that curve to the left. How do we take the population level approach? And for this, I have turned to my my favorite pun, the brain health equality tree. And we have two trees here. On the right-hand side, we have a healthy tree, healthy roots, healthy trunk, and very healthy brains, you can see here. And the brains, I would like you to imagine, are the fruits of our tree. And on the left-hand side, we have a tree where the brains are diseased, the leaves look a little bit discolored. They would have been more discolored, but I couldn't get the AI machine to do what I wanted. The trunk's supposed to look a little bit shriveled, and you can see the quality of the soil's not up to much. And so the reason I like this metaphor is because if we think about the brains being the fruit of the tree, we can spend a lot of our energy trying to influence those, and that would be your individual level approach. But of course, if we don't spend energy in trying to fix the distal, the proximal branches, the trunk, and the roots, which I've labeled here as those distal branches just holding onto the fruit will be your health behaviors, your immediate social networks. And then as you come down through the tree, you get further out into the community. So community assets, social determinants of health, like education, like occupation and the labor market, like pollution, and the built environment around us. And then right down into those deep societal factors, which are our roots. So we're thinking about things like structural racism and sexism, climate change and poverty and populism. If we don't fix those things down at the bottom end of the tree and the roots, then the next generation of fruits that come through each time will have more and more diseased brains because we're not fixing the root cause of the problem. So the population level approach that Rose is talking about is trying to operate as far down this metaphor as we can. The trade-off is that the further down you go, the harder it is to do anything, and the harder it is to measure things. And academics, we like measuring things and being confident that what we're measuring is definitely what we're wanting to measure. And so that makes it much more difficult. And so we tend to gravitate without conscious effort up towards the top. So keep that metaphor in mind. We therefore defined our population level approach as some kind of measure, so an intervention or a policy, which is applied to a group of people, and that might be a whole population, or it might be a specific subset of the population or a specific community, with the aim of changing the social condition. So that's the really key bit. We're not asking individuals to consciously change things necessarily. What we're trying to do is change the social conditions so that the environments that they interact with are more, either more conducive to protective factors or less conducive to those risk factors that we talked about. And the reason I say that we're not necessarily pushing individuals to drive the change is because we need to think not just about the reach of our intervention, which is on this y-axis. Are we trying to reach lots of people or just select individuals? But we also need to think about the types of agency that are required in order to benefit from our intervention. So agency means resources, and that can be financial resources, but it can also be the community assets that you have access to. It can be having time and headspace to actually think about your long-term health rather than firefighting your needs today. And typically we see that socioeconomic patterning that Carol was showing very clearly for stroke and other and risk factors, that in more disadvantaged communities, people will have less agency. And so if your interventions are all on the right-hand side of this, if they're all pushing individuals to make the change for themselves, then we will typically see that the people who are more affluent will find it easier to do that, and we'll widen health inequalities. So if we're trying to lower health inequalities and have a very effective strategy, we want to be trying to be up at the top left here, population reach with low agency. So things like reformulating products. So I go to the same shop and buy the same product, but it's got less of the bad stuff in it, rather than telling me to buy something else, which I might not have access to or might not be able to afford. Okay, just a couple of other points before we move to the next section of the talk, which didn't really fit anywhere, so they're sort of here. So stay with me as I meander through these next couple of slides. So we recognize now, I think, in clinical medicine, the importance of co-production, co-design of research, working with the public and with patients when we do clinical research. It's a little bit tricky when we do this kind of research to decide who are consumers or who our public should be. I think policymakers are clearly a very important group because we want to influence policy, and therefore we need to produce research in a way which is useful to them and answers the questions or the residual concerns that they have. And so that's what we did at the start of my PhD work. We interviewed English policymakers about their views on dementia, risk reduction policy, and this balance specifically between individual and population level approaches, is very difficult to present qualitative findings on a slide, I discovered. So I haven't tried. But the key thing for this talk, I think, that we discovered is that actually generally there was an acceptance either upfront from the policymakers that we needed a balanced approach and we needed more population level emphasis, or we kind of got there through a series of questions and examining their assumptions. But then there was the challenge that they didn't feel they had the right kinds of evidence to help them actually do that. So that's what we've been trying to address since then. And to back that up a little bit, this was a rapid review we did of dementia systematic reviews. So we found 12 systematic reviews, I think 12, or maybe 13, systematic reviews which had looked at dementia prevention interventions of some kind, either risk reduction interventions or trying to target dementia itself. And we then categorized the interventions within all of those reviews as to whether they were individual level in the first column or meeting our definition of a population level approach. And we effectively found that of the 600 interventions covered by the reviews, there was effectively no population level evidence. And then there's always the question of, this is a big systematic review with lots and lots of references. How much did the population level evidence actually influence what they were saying? And that was even less. So very little population level evidence to date. Okay, so the last section of the talk is then saying, well, if we've defined a population level approach and we've determined that we need one and that we haven't really had the evidence to support one before, what should it look like? And the challenge here is that we have very little, if any, evidence for population level interventions, so changing the social conditions and pushing the risk curve to the left, actually reducing dementia directly. So what we have done is tried to find population level evidence where we have interventions which shift the risk curve to the left, change the social conditions, and result in less of the risk factors for dementia in a population who do not currently have dementia, on the basis that if we accept they are causally related to dementia, we should then be able to model the effect on dementia. So you've seen this from Carol before. This is the 2024 Lancet Commission report. When I was doing this work, we were working to the 2020 report. So we actually did not have cholesterol or vision loss as our 12 risk factors that we looked for evidence on. Of course, there are more risk factors for dementia for which the evidence base is still building. And actually, you could really examine the evidence base for any one of these and decide whether you think it's enough. But from a consensus-based approach, we have these 12 that we worked with. Oh, I'm stuck. So this is a deliberately messy slide. This, if anyone's done a systematic review, is our adapted Prisma diagram. This is really to show that point I made before, that if you do anything at the population level, it becomes very complicated. So we had to do a carefully constructed and multi-stage search process. But we did lean heavily on work that the Cochrane Library had done and the WHO have done, where they've actually done a lot of the heavy lifting of synthesizing this evidence. And then we did more targeted kind of systematic reviews for other areas. And then three of us, Lindsay Wallace and Naheed McAdam, independently, we looked at all of the evidence for a given policy or a given intervention. And we each decided independently whether we felt there was a signal that this intervention can work for some people, but we don't really have a consistent or comprehensive evidence base. Whether we had consistent and a robust evidence base, but there was a limited number of contexts or information about who tends to benefit and why, or whether we had a really strong evidence base. So that was our kind of modified evidence grading approach. And for any policies where we decided as a consensus of the three of us that there was moderate or high confidence, so we had a consistent and a robust evidence base, we produced this population level framework, which you won't be able to read all of, but we have the types of risk factors we were looking at down the side here. Of note, we found no moderate or high confidence policy recommendations for public mental health, so depression, social isolation. And then the types of interventions are along the top. So fiscal interventions, marketing, availability, and legislative. And we've stratified this whether we have high or data from high mid or low middle income countries, and you can see there's a reasonable mix. Although we had a very insightful presentation yesterday from Rufus Akinyemi about the need to increase the evidence from low middle income countries in particular. Just to pull out a couple of examples here. So we're talking about things like taxation policies on tobacco, alcohol, and sugar sweetened beverages. Measures to try and reduce things like traffic density, so low emission zones and other legislative approaches. And then things around occupational protections for hearing loss, as an example. So there's evidence of almost halving of instant hearing loss amongst occupational groups if we provide appropriate protection for exposure to loud noises. And for each of those individual interventions, we produce these summaries, which we hope will be helpful for those working with policymakers to give the effect size and the sources of evidence, but also give the key contextual considerations and where they can find further planning or implementation guidance, often which has been done by the WHO. We then went on to model this. So we had a model which was produced by Robert Anderson at LSE, and we had the risk factors for the UK or the English population, the prevalence of them. We had the transition rates into dementia from Carol's CFAS studies, and we had the effects of these interventions on mortality from things other than dementia from meta-analyses. And then we used the Lancet Commission's relative risks to model the effects through to dementia. That all sounds very complicated. Do feel free to have a look at the paper. But effectively, what we determined was that these interventions, which I'll read out because they're a little bit small, so minimum unit alcohol pricing, raising alcohol taxation further, further reformulation of products to reduce dietary salt to have an effect on hypertension, or dietary sugar to reduce obesity, low emission zones, further rollout of those across England, taxation policies on cigarettes, and then mandation and provision of helmets to children who are cycling to reduce traumatic brain injury. All of these within this model were cost saving, specifically for their effect on dementia, after we've accounted for effects on other non-communicable diseases, after we've accounted for competing risk of mortality as far as we could, the cost came through as cost saving. I think there's more work to do in the health economic space for sure, but this is a kind of first step, hopefully. So returning to my central question, how do we reduce dementia morbidity by as much as possible? Hopefully I have persuaded you that what we need to do is a population level approach, and at least that needs to be a major part of our broad strategy, and try to shift the curve to the left for large swathes of the population through social, societal level change, social condition change. And we've started to produce the evidence that can help those working with policymakers to actually drive policy change in that way. Just some last thoughts. So there are challenges to this approach, some of which may have appeared in the chat, depending on how confrontation everyone's feeling. So often people will say, well, the problem with thinking at this level is that individuals need support. And I totally agree with that. And I don't think we should stop doing research that supports either individuals who want to know what they can do to lower their own risk, or research to support those with subjective cognitive decline or who are needing secondary prevention, tertiary prevention support. So it's not saying that that is not important. It's just a separate line of research, I think, although there's interdependencies that we can learn from each other. In particular, around causal inference. Causal inference is very difficult in this population level space, and we need the individual level research to help actually shore that up. And we also need to continue to work collectively with a kind of long-term strategy to try and build some of this evidence base. One size clearly doesn't fit all. And one of the themes that we've been discussing here in New Zealand is about how we tailor these kind of macro population-wide evidence bases to specific populations or specific population groups. And we need to find that balance and maybe move away from the caricature of population level and individual level and think about things around the community level and the neighborhood level where these things interact. If I have a great drug that works, there's no political pushback to me giving it to people or offering it to people. But these things, these kinds of interventions we're talking about, they affect civil liberties, they're politically controversial sometimes, and that does introduce a level of complexity and challenge here to driving policy change, which is why we need to work with policymakers, I think, and the public. And then this point about NCDs, so non-communicable diseases, so other diseases like obesity and heart attacks and strokes, diabetes, some of which are risk factors for dementia, some of which are probably bidirectional, but also exist as their own things. And there is an overlap here, which is probably a good thing if you're a policymaker, if you have a limited budget and you've been told that all these things will work synergistically. But they also gives us challenges academically, I think, and also maybe in the kind of advocacy space as well. On the flip side, we have opportunities. So we have been discussing here, and we continue to discuss at this meeting, novel study designs, including how we might develop intermediate markers to enable some of that causal inference work to be done. So can we actually, when we do our social change intervention in midlife, are there measures of brain health that novel biomarkers and other things we can leverage to actually know that we're reducing dementia risk, because we know that there's robust evidence linking some kind of brain health or cognitive health markers in midlife to risk of dementia down the line. We need to continue to work with policymakers, and I think there's got a lot of low-hanging fruit in that space to really understand what type of evidence they want, and that will differ in different contexts. And then I think this interaction with non-communicable diseases, it's not going away, so we need to work out how we leverage that to advance this particular area of research. To that end, we have set up the Population-Level Approach to Dementia Risk Reduction Research Group, with whom we are here in Auckland. And if you're listening and you feel like you have something to contribute to that group, please do get in touch. We very much welcome people to join us in that. It's clearly a big, knotty challenge, so we need lots of hands on deck. And lastly, thank you to this is a small selection of the people that have helped me, but if I add any more, then the pictures get too small to see, and my funders. And also, please do get in touch. I'm on Twitter, Blue Sky, LinkedIn, etc. I learn a lot from the interactions with other academics on those platforms, or do email me. Thank you very much.
Thank you so much, Seb. That was a wonderful talk. Come join me in the picture because we do have a question for you.
Okay.
So Antoine is asking, first of all, many thanks for the talk. And so the person is wondering if we try to decrease the risk of dementia, for example, by lowering cardiovascular risk factors or other risk factors, isn't there a risk to finally increase the risk of dementia because people will live longer with age being the main driver of dementia?
If I could have planted a question, it might have been that one. Thank you for that question. So this gets into an area of research called compression of morbidity, which is an interest of mine. There's a brilliant paper by Claudian Dana and colleagues, which was in the BMJ. So if you search for Dana, D-H-A-N-A, and BMJ, I think 2021, and they looked at this exact question. So if we do manage to lower people's risk profiles, clearly people will live longer. And Carol has shown how exponentially linked dementia and age are. But she also showed that decoupling of those two things in the CFAS2 studies. And what Claudian's team found in that analysis on a cohort from Chicago was actually that although people live a little bit longer, if they have better cardiovascular profiles, the age at which they get dementia is pushed back by more than the age of death is pushed back. So you squeeze the number of years lived with dementia into a smaller amount of time. Now, I think we need more studies in that space. And in fact, we have some, I think, planned as a research group going forward. But there is evidence to suggest that what we would actually achieve is a compression of that morbidity. So we get a longer, healthy life expectancy, brain healthy life expectancy, also a little bit extension of life, but actually it difficult to kind of summarize. But yeah, I think less absolute years lived with dementia based on that evidence.
Brilliant. Thank you so much, Seb. Before we introduce our third speaker for today, I just want to do a quick shout out to Sarah Cullum. Sarah Cullum is also a member of our research group, but unfortunately she couldn't be here with us in Auckland, but she's joining us from the UK this morning. And thanks, Sarah, you are a main driver of dementia research in Aotearoa New Zealand. You're greatly missed here. And thanks so much for keeping an eye on the chat and helping responding questions. Great you had the time to join us. It's getting late in the UK for you and Carol as well. So And also for those asking about the recording, yes, we will make the recording available as well as the slides. So everyone who has registered via Eventbrite, which is, well, basically all of you, we will share the resources via email in a couple of days. So that leads us to our third speaker of the day. Many of you may know him. Dr. Aotearoa is a senior lecturer in psychiatry here at the University of Auckland and a consultant old age psychiatrist with a Te Whatu Waikato. His research interests include Pacific mental health, old age psychiatry, and dementia prevention. He was the lead author of the Dementia Economic Impact Report 2020. You've already heard a little bit about that today, which highlighted the significant societal costs of dementia and the inequitable utilization of dementia services across different ethnic groups in Aotearoa. He spearheaded some key publications that really underscore the differential dementia risk across diverse populations here. And his talk will basically dive into that and ultimately make the case on why population-level approaches to dementia risk reduction are so much needed in Aotearoa. So over to Etu.
How about I drive this thing? Okay, so kia ora koutou, malo lele. Thank you, Suzanne, for the introduction. I'm never ever too sure who writes these things, because they seem to make you sound a lot more fascinating than potentially you are. Look, my role today is really to follow on from Carol and Seb and to try and put population level approaches to dementia risk reduction into a New Zealand context. So what I thought we'd talk about today is, one, we'll talk a little bit about the societal cost in New Zealand, so we'll touch a little bit on the economic report, really to highlight the inequities that we know exist within populations within New Zealand, particularly Māori and Pacific populations compared to the European majority. And then we'll kind of look at some of the evidence that we've come up with along the way around what it might look like if we can start targeting these inequities and see what we can do going forward, particularly around risk reduction. So I'm very pleased to have in the room here Catherine Hall, who is the CEO of Alzheimer's New Zealand. Alzheimer's New Zealand has been banging the drum since 2008 at least. So we now have 4 economic impact reports, the most recent of which was 2020, but there were 3 before that, and all 3 reports talked about the increasing costs and the tsunami of older age coming through as the baby boomer generation started to hit retirement age. And we know that around 2011, the first of the baby boomers hit 65. So we have this massive bulge of older people coming through that are really going to spike our dementia numbers over the coming years. So in New Zealand, we know that in 2025, we've probably got around 85,000 people with dementia throughout the country. In the next 5 years, that's going to grow another 17,000 people to about 100,000. And then by 2050, getting close to 170,000. So the number of people with dementia in New Zealand is going to double in the next 25 years. And we know that those costs that go with dementia and the societal cost are significant. So in our 2020 report, we estimated the economic cost in Aotearoa to be around 2.5 billion. Based on population aging alone and the increase in dementia numbers, we're at about 3 billion now. But we actually know that that's not taking into account inflation, it's not taking into account change in the consumer price index or any other increase in costs. So while we've gone up by what's that, about 20% in the last 5 years, we know that the real costs went up from the 2016 report to the 2020 report by about 40%. So chances are these are an underestimate. And if you add 1% inflation on to that 2050 number, annual inflation, you're probably looking at around 8 billion. If you add 2% inflation, you're crossing 10 billion. So, this is going to put unsustainable strain on our health system and on our society. And one of the difficult things about things like economic costs is that they don't really take into account unpaid care. The care that people provide, that is not funded by the government, that then falls on them as individuals out of their own pockets. So in 2020, we estimated that we were providing about 1 million hours a week of unpaid care. And with the increase in numbers, we're now at about 60 million hours a week. And by 2050, we're looking at 125, 130 million hours per week. And these are reasonably conservative estimates. But 1 million hours a week of unpaid care is a lot of time that people are having to put in to caring for loved ones, and therefore carrying that cost of what they could be doing otherwise, the opportunity cost. We know that because of the age structure of the New Zealand population, Māori, Pacific and Asian populations are quite a bit younger. Our median age is a good 12, 15 years younger compared to the national average. This means that over time, our numbers of people with dementia are going to increase much more significantly compared to the Pākehā majority. So while the European numbers with dementia will potentially double, Māori, Pacific and Asian populations are going to triple in that same 20-year period. And that means a couple of things. One, the burden is higher in people that are already marginalized. But two, it also means that a lot of our services that are designed for that majority population are going to be less and less fit for purpose as that majority starts to shrink. This is a slide I generally use when teaching my med students. But it's really just to say that if you think about the entire dementia journey, we fail at every step of the way. And particularly for our Māori and Pacific populations, we know that irrespective of the number of people that develop dementia, because of issues around health literacy, because of stigma, because of different conceptualizations of what cognitive change means and its impact on families and societies, we are just not coming through the door to get a diagnosis. So we know from work that we've done that about half of dementias in New Zealand go undiagnosed. And when you look at Māori and Pacific populations, it's a wee bit higher again. We know that even in those who get diagnosed, about half of Pacific people who get diagnosed are already at a moderate severe stage of dementia. So that means they're coming in late. Coming in late means, you're missing out on potential disease-modifying treatments like the cholinesterase inhibitors, and like cognitive stimulation therapy. It also means that that burden of care is falling on families at home and people who are undiagnosed, and in New Zealand where you generally need a diagnosis in order to access funded support. And then we also know out the other end that even in those who have a diagnosis, our uptake of services, our uptake of the funded support systems is a lot lower compared to the total population. And another, number of reasons for that. One, it's around health literacy, but two, it's around actually the perception of the services that are on offer and whether they're actually fit for purpose. One of the difficulties with economic costs is that if you look at the economic cost across a population, it kind of lumps in all the costs together. And what it doesn't really differentiate is the costs that are falling on families compared to costs that are, say, falling on the state. So what we have here is the 4 big ethnic groups for New Zealand. And looking at the bottom bar there is the amount of spend per person with dementia in aged care. And that smaller, lighter bar at the top is the spend on community care. And what you can see quite clearly here is that compared to the European majority, the other ethnic groups are spending about $4,500, $5,000 less per person with dementia per year. So they're receiving, $5,000 less support from the state. And that means that that $5,000 must be being carried by them somehow, probably in the form of unpaid care. We know that, Pacific and Māori and Asian populations are actually doubly disadvantaged. Because of our younger age structure, a much greater proportion of a population is under the age of 65 when they get dementia. If you're under 65, you're leaving the workforce early. So you're getting that double whammy of leaving the workforce early, but also having to have someone stay home to care for you in the form of unpaid care in order to compensate for that. So when you kind of add that all together, it means that, you know, for your average Māori or Pacific person with dementia, it's costing you about $10,000, $11,000 per year per person that you are carrying as your family because you're just not accessing that assistance from the state. You've left the workforce early and someone else has to stay home to look after you. And it's that inequity that we really need to think about. All of those estimates so far make the assumption that it's just an aging population that is going to change our dementia numbers. But what we know from work that Gary Chung and Sarah Cullinan have done is that if you look at the age standardized prevalence of dementia, we know that Māori and Pacific people are 1.5 to 2 times more likely to have dementia. So we have a higher prevalence anyway. And that's kind of the segue into this population discussion. Because the question is, why do these populations have a higher prevalence of dementia, you know, compared to our total population? And as, you know, Carol and Seb and a lot of people have talked about over the years, you know, it comes down to risk factors. I've deliberately chosen the 2020 Lancet Commission here because when we replicated in New Zealand, that's what we replicated. So as an example, you know, in 2020, Jill Livingston and the Lancet Commission estimated about 40% of dementias worldwide would potentially be preventable if you completely eliminated 12 risk factors. When we repeated that in New Zealand and then looked at it stratified by the different ethnic groups, we're getting about a 10% higher risk, you know, for Pacific people and Māori because of that burden of risk factors. And there's, you know, a wee bit higher than the Europeans and quite a bit higher than our Asian population, purely because of risk factor prevalence. And the question then becomes, you know, is there something inherently risky about being Pacific, about being Māori, about being an Asian that increases your risk, or is there something else driving this? Okay. One of the interesting things about a population attributable fraction, you know, that kind of estimate of, say, 40% of dementias are preventable, is that it's kind of a snapshot in time. We know that, one, we're never going to completely eliminate any risk factor. And two, we know that because of that lag that everyone has talked about between the accumulation of risk factors, the impact of damage they have on the brain, and then the subsequent neuronal injury, degeneration, and dementia, means that there's probably a 10, 20, 30-year lag between symptom onset, between risk factor accumulation and dementia onset. So what we've modeled here is a hypothetical midlife intervention that says if we took people aged 40 to 64 in midlife when you've got these risk factors and looked at what happened if you could reduce those risk factors by 15% or 25%, what would it look like over time? And what you can see are two things. One is that actually at 10 years, even with a 25% proportional risk factor reduction, the impact is, it looks quite small, but it does accumulate over time. So we know that by 30 years, you know, potentially in New Zealand, we could have prevented about 11,000, 12,000 cases of dementia if we'd reduced the risk factors by that amount. But it really highlights to policymakers and, you know, to our health system that we need to be thinking now about prevention measures because it's going to take such a long time to accumulate those changes over time. And if you look at this by ethnicity, what you can see is that actually the benefits for Māori and Pacific peoples is a lot higher than that for the European majority because of a higher risk factor prevalence, because of our different age structure, because of differences in things like mortality. If we put exactly the same intervention in that could reduce that risk factor burden, you're getting about a 25, 30% increased benefit, you know, in these marginalized populations compared to the total population. But, you know, as Seb has kind of alluded to, you know, what is actually achievable? Where can we actually target? And he's talked about his tree, and he's talked about the fact that actually there are low-hanging fruit that look easy to target and easy to measure, but aren't actually getting to the root cause, or there are more difficult decisions and policy decisions that need to be made, but that are going to cost a lot more and require a lot more political will in order to bring them to fruition. So I think just to really quickly summarize, when we think about whether something's achievable or not, as Seb has talked about, it's not just about the risk factors, it's about what's driving those risk factors. And we know that our environment matters. We know that the areas that we live in, that we work in, that we play in, where our community sits, is going to influence our risk factor burden. These are just some examples of population-based studies that have been done in New Zealand by the likes of Boyd Swinburne from here at University of Auckland, and University of Canterbury, a couple from Otago, and they all basically say the same thing. If you look at tobacco and vape shops, as you move into areas of higher deprivation, the density of tobacco and vape shops increases. The same happens for fast food outlets. The same happens for alcohol outlets. And the reverse is true for things like green spaces. So where we live, where we work, where we play is really influencing the way that we are able to live our life, the way we're able to make healthy choices, and how easy it is, to mitigate some of those risk factors. So what we've shown recently in a New Zealand setting is that as you go up by level of deprivation, your risk of dementia increases. So people in deciles 9 and 10, the most deprived 20% of New Zealand society, have a 50% higher risk of dementia compared to people in deciles 1 and 2, the most affluent 20% of New Zealand society. And we know that risk factors cluster around disadvantage. They cluster around poverty and deprivation. So what we have here is data from the New Zealand Health Survey, stratified by deprivation. And basically, you can see for everything except alcohol, which goes the other way, that as you go up into more deprived areas of New Zealand, your risk of a low education increases, your risk of obesity, hypertension, living alone, physical activity, they all have exactly the same trajectory. So it's not surprising then that if you live in an area that's more deprived, you are going to have a high burden of risk factors. That is what you're surrounded by. So what this slide shows is, that 40% potentially preventable from the Lancet Commission, and that, 50% potentially preventable in Māori and Pacific, and the 48% preventable in European. This is what it looks like if you stratify by deprivation. And what you can see are two things. One, the pattern is exactly the same for all 4 ethnic groups. Māori and Pacific people who live in affluent areas have low risk. Europeans who live in higher areas of deprivation have high risk. This is not about ethnicity. This is about deprivation and the social determinants of health. And when you look at deprivation as a population, you can kind of intuitively see why Māori and Pacific people are overrepresented. So for Māori and Pacific, a really high proportion of our population lives in that most deprived 20–30% of New Zealand society. In fact, for Pacific people, about 35% of our population live in decile 10, the most deprived 10%. And you compare that to Europeans, where it's roughly 10% across the board, which by definition is what a deprivation index is. So deprivation is not just about risk factors, it's about everything that influences those risk factors, from the environment that we live in, from our ability to access healthcare, that if a risk factor like, say, diabetes or hypertension happens, that we're able to get it treated in a timely and appropriate way, that we can access, treatments for risk factors, treatments for dementia along the whole continuum. And deprivation is a really interesting concept because it's kind of a catch-all for everything that's affecting our risk factors. And we can see it in the Lancet Commission. So in 2017, they identified 9 risk factors and 35% preventable, add 3 more risk factors, 40% preventable, add 2 more risk factors, again, 45% preventable. And bearing in mind that the Lancet Commission is only going to include risk factors that are biologically plausible, but also that have enough evidence to justify their inclusion. So there are probably many other risk factors like diet, like sleep, like anxiety, like stress more generally, that potentially are driving your risk of dementia, that are very likely associated with social disadvantage and deprivation, that we're just not capturing when we focus on these specific risk factors. So the question then becomes, as Seb has talked about, how can we shift that curve? So what we've been modeling here is just a hypothetical example of what would it look like if we took people living in the 50% more deprived area of New Zealand and shifted their risk factor profile to that of the 50% in the highest area. And you can see that for 10 risk factors that we had available data for, you get that kind of gradual increase to about 2%. If you didn't focus on risk factors and said, okay, what about if we just shifted deprivation and change that, you get about 3 times the result. So you go from about 2% to about 7.5%. And don't get too hung up on the percentages, because you could play the numbers any way you wanted about whether you wanted to shift, deciles 2 to 10 through to decile 1 or whatever else. But it's a really good example of saying, if we just focus on risk factors, we'll get some benefit. If we focus on the drivers of risk factors, we'll get a much more pronounced benefit. And just as a reference point, even if we just shifted half of the people in decile 6 to 10 to 1 to 5, we're still getting more bang for our buck than just focusing on those risk factors. So then, if people that are Māori, people that are Pacific, who cluster around higher areas of deprivation, what happens if we shift them? And the results are much more pronounced, and you're getting twice as much benefit from shifting deprivation in, say, a Pacific person compared to a European person, just because of the way that the deprivation sits in New Zealand and our clustering around areas of higher deprivation. So anything that we can do at a policy or legislative level that will improve poverty, that will improve social disadvantage, is going to also reduce inequity. And you probably can't talk about deprivation without considering the roots that Seb talked about, and that's actually the underlying social political structures, the economic structures, the racism, the colonization, that general oppression that has occurred in these marginalized groups over generations that has led to them living in more deprived areas in the first place. So look, at a population level, as Carol and Seb have both talked about, we need to be thinking about how we can target modifiable risk factors for dementia, how we can reduce that risk in order to then reduce that flow and effect down the line. But in the meantime, on a pragmatic level, we still have to think about the people that do have dementia. We still have to think about the people that are still coming through our service or that we're not picking up, and trying to put in place as much as we can to improve their access to diagnosis, to upskill the workforce, to meet these diverse communities and their needs, and to design services and supports that will actually be beneficial and that they'll actually want to use. So that's why I wanted a really quick shout out to my Pacific Dementia team. They are one of 7 Ministry of Health Budget 22 initiatives, where the Ministry of Health funded 7 pilot studies across New Zealand, some Māori, some Pacific, some mainstream, to basically say, we know the system is failing. Is there a way that you can tailor a service, tailor your messaging, tailor your support systems to try and improve every aspect of that journey? And in our situation, ostensibly the funding was for post-diagnostic supports. We realized very quickly that actually we couldn't support people who weren't even coming through the door. So Devita Vungamoeahi there in the top left, our manager, has kind of pivoted the entire service, and we've shifted upstream. So we run community awareness workshops. We have a weekly radio program in Tongan that is trying to get that message out there. And we're getting a lot more people through the door that we can then assess and, support as best we can. So in summary, we have unsustainable cost increases coming with the surge in prevalence. We know that unpaid care and the burden on families is significant and is going to grow. We know that there are significant inequities in the provision of care. And as the Marmot Review said, health inequities result from social inequities. We have to act on health inequities, in order to address the social determinants of health. Finally, I want to leave you with this quote from the late Whaanana Efeso Collins. So he's a member of parliament that died unexpectedly last year. And my social media feed just happened to be filled with, tributes to him because it's been a year on. And he was with the Green Party. He was very much a social activist. And in his maiden speech to Parliament, he said this, it's hard to be poor, it's expensive to be poor, and now it's socially unacceptable to be poor. And I think that's the narrative that we need to shift. Thank you.
Thank you so much, Etu, for another insightful presentation. Before we head into a Q&A with all our panelists, we have a specific question for Etu. Or more or less maybe a comment. So we have a person saying, it would be interesting to look at levels of dementia in rural areas, and specifically at factors like the use of agri-chemicals, etc. So what are your thoughts on this?
No, absolutely. Look, the Dementia Action Plan that, Catherine Hall and Dementia New Zealand have championed, one of the 4 target areas were Māori, Pacific, younger onset, and rural communities. So we recognize that rural communities are underserved. As far as, agri-chemicals and other pesticides and that go, people like Steb are probably better placed to answer these. But generally speaking, I think anything that affects your physical health, anything that's going to affect heart health, brain health, or your general health all round is not going to be good for your brain and is probably going to increase your risk of dementia. That's my thought.
Thanks so much. If it was to you, what would be your priority? There's so many different factors that influence dementia risk. So if you could make policy changes, what would you do here in Aotearoa?
Nice and nebulous question. What would you do, Catherine?
I can't answer that. I think that's a question.
So giving the audience a little glimpse at our workshop. And yeah, we have Catherine Hall in the room.
Yeah, I think you could target so many areas. But I think fundamentally, as Seb's talked about, we need to be thinking about interventions at a population level that will reduce the risk by a little bit for a lot of people.
Brilliant. Thank you. We do have a question for Carol. Yes, Carol is still with us. You've been talking about gender differences across time. So people are wondering why the decrease in dementia incidence may be lower than for men. Any insights on that?
Well, it's an interesting question, and it does appear to be more looked at in these combined analyses. It's more in men than women, but it's not entirely consistent across the different countries that have been studied. And just to say that even though in the UK the incidence dropped dramatically in men, if you look at the cognitive trajectories, in fact, women had an improvement in their cognitive impairment-free life expectancy as well as men. But one of the things that's been put forward particularly is the fact that men were more likely to have smoked. So the smoking epidemic has changed across the generations that were affected, and so that's one big difference. There are huge gender differences in smoking patterns across time, although of course smoking picked up in women, so you then might expect a decrease in women, an increase in women, and then a decrease to be associated with smoking. So it's quite difficult because you have to look at the transgenerational patterns of these risk factors. Men were also more likely to have vascular partly cigarette smoking, but also partly higher risk more generally. And those were being more addressed more effectively, both at kind of upstream prevention, but also more effective treatments. So that's so it's a complicated picture, but I think smoking does play a part and might explain some of it.
Thank you, Carol. We have another question that I would like to hand over to Seb. What do we know about the effects of stress and sedentary lifestyle on the risk for dementia?
Good question. I mean, they're two separate points, right? Stress and sedentary lifestyle. So sedentary lifestyle, I think the Lands Commission includes physical inactivity. And as with all of these risk factors, you get into a space where it becomes quite difficult to measure some of them. And so things that sometimes go into things like the Lands Commission are the things that we can measure. So, for example, smoking is a good example. We have pack years, it's a very easy kind of measure. But other things like diet, it becomes really difficult to actually decide what it is you're talking about. Even for sleep is another example about that. And stress would definitely be an example where actually you need some kind of validated measure that you can be confident measures the same thing across different groups. So I think sedentary would be probably kind of covered in that basket of physical inactivity, which interacts with your diet to reduce your kind of cardiometabolic risk and also your blood pressure, etc. And stress is complicated. In the Lancet diagram, they have it actually as one of the red bits. So I had the blue risk factors and then the red kind of mechanistic changes that occur in the brain, and stress and inflammation were kind of placed in there. I think it probably plays a role across both, you would expect. But it's probably a bit too nebulous to really measure in a way that those kinds of analyses require for inclusion.
Brilliant. Well, thank you very much, Seb. Oh, we just had another question pop in, or a comment. That might be another one for Etu. In deprived and rural areas, they should lower the amount of fast food, vape, and alcohol shops and increase the education on living off the land and growing own food, teaching kids basic living cooking skills for the future. And the 4 No's is a good example of that. Etu, would you like to comment on that?
Oh, look, I completely agree. Sometimes I reflect on when I look back at pictures in Tonga of the 1970s and look at pictures of people in Tonga now, and people in Tonga now are a lot bigger than they were 40 years ago. And that is the influence of, the Western diet, the Western lifestyle, the ultra-processed foods. And I think you're right, going back to living on the land, going back to, there's a really cool concept that I came across a couple of years ago. It's called know the whakapapa of your food. Basically, know the genealogy of your food. And if you can trace your food back to a source, then generally that's probably going to be good for you. But if you have random chemical numbers in your ingredient list that you're not too sure what they are, then potentially those aren't as good for you. Also, to quickly answer the question on stress, we have a paper under review at the moment, which looked at psychological distress as a one-off measure in time and looking at incident dementia after that. And we have shown that people who were rating higher in psychological distress, there's a definite trajectory. So that people rating the highest had probably about 2.5, 3 times the risk of incident dementia over a 10-year period compared to people that didn't meet that threshold for distress.
Thank you, Etu. So we're about to wrap up the session. Thanks everyone for joining this morning and taking time out of your busy schedules to be with us. I would like to invite Carol to share some final thoughts. Carol, if it was about you, what would your top priority be when it comes to population level approaches to dementia risk reduction? What changes would you like to see?
I think there are kind of 2 major things. One would be to to address efforts to look at inequalities in populations and do everything that you can from conception, health of parents, right the way through. And that's and that doesn't have the full evidence base that Seb was talking about. So, we're constrained by the evidence base. So the other thing is so that is something that societies need to do, is address inequalities in society. And the other is to improve the evidence base on how we do this, the kind of the brick building within that, and rebalance the research budgets. So that although the individual stuff is important and the drug discovery and so on is important, it has had the lion's share. I mean, we put all our eggs in, as societies, we put pretty well all our eggs in those baskets, despite the fact we have all this evidence now about inequalities and the clustering of risk factors that has been so eloquently described by the other two speakers, by Seb and Etu, which is fantastic. So I'd want to see high-level action on both fronts. And I have said that many times to our own system.
Well, thank you so much, Carol, for joining us. And I'm going to invite Seb to also share his thoughts on what would you do?
Thank you, Stan. Well, I have very little to add to what Carol says, which is often the case. I think that just one reflection is we talked yesterday here about the long game. And I think we have to recognize that when you have complex questions, there aren't simple answers. And that might not be, sometimes we want our top priority or our single thing that we would do. But if that's not where the evidence leads us, then that's not where we are. So we have made important steps, I think. I mean, Carol's described decades of evidence, but even in the last 5-6 years, we've really gained some traction, I think, in the dementia risk reduction research field for this approach, and building this research group and having this meeting. So I'm kind of positive and optimistic in that sense that we're taking the right steps to build that evidence base. Not that there won't be challenges along the way, or that it will be easy, but I think we have to meet the evidence where it is and the problems where they are, and then take that forward. And my other big reflection, I think, is this idea about, which is just because we're here and there's such rich evidence from the New Zealand context specifically, we have to, there's a kind of research thing about how we balance place and local tailoring and local knowledge and local needs with that kind of big picture, papers that we put in journals, and the kind of lived reality, and then the academic. So yeah, so I'm optimistic. I think we're taking the right steps, but also we have to recognize it will be a long road, and we just be strategic and keep kind of identifying steps and moving forwards.
Brilliant. Thank you so much, Seb. A huge thank you again to our presenters, Carol, Etu, and Seb. Thanks to everyone who joined this morning for your engagement, for posting questions, for posting your thoughts on what we should prioritize. It will definitely help to inform our discussions, which will be ongoing today and tomorrow, and we will not get tired to work on dementia prevention. There's so much room for brain health improvement, and being optimistic about dementia risk reduction. I totally agree with that, Seb. So thank you all. Have a good day, and we will see each other again soon, because this is an ongoing conversation and a long-term vision that we all share. So thank you and goodbye.